the first presentation. It's an honor and pleasure to have here Professor Alter, Harvey Alter, Nobel Laureate in Medicine with hepatitis C, the end of a beginning or possibly the beginning of the end. You'll soon understand what he means with those. Professor Alter?
Okay. Thank you, Florian. And thank you. I must say that yesterday's conference day was one of the best I've been to. It was so intriguing to see all the different disciplines and excellent science. So, that is my story. The title is what I'm going to tell you. We're at the end of the beginning, really, and I'll show you why. And there is a possibility that this is the end of hepatitis C. So, sustainability has been the topic of this conference. We heard a lot about it yesterday. We'll hear much more coming on. But I've chosen to talk instead about unsustainability. And by that I mean, I want to show how we can make the hepatitis C virus unsustainable. And I think you'll see how that can work. Now, when I won the Nobel Prize, I received this congratulatory card that said, "There is no elevator to success. You have to take the stairs." And I found this to be so true, and the message I give to young people, Davis, are you listening? This is for you. So today I'm going to take you through the steps that led to the discovery of hepatitis C, and then the steps that will lead to the eradication of hepatitis C. This all began back in the late 1960s, early 70s, when we were addressing the question of how often do people get hepatitis after a blood transfusion, and if so, why? And we did this in open heart surgery patients because they received a lot of blood, an average of 18 units of blood per procedure, and because they were healthy people except for their heart trouble. They were not immunosuppressed, so they would produce antibodies if they were infected with something. So the patients went on a heart-lung machine, and the key to this is that it was a prospective study where we obtained samples every 1 to 2 weeks post-transfusion for 3 months, and then for each month for another 3 months. If we had not done that prospectively, if we just waited for people to have yellow skin or symptomatic hepatitis, we would have missed most of the cases, because most of hepatitis C is initially asymptomatic. We didn't have much to assess hepatitis in those days. The main thing we could do on each sample is to test for elevation of a liver enzyme called ALT, alanine aminotransferase, which goes up when the liver is inflamed. We had very early tests for hepatitis B, a little agar gel, very primitive test for hepatitis B. And it wasn't until much later that we could do PCR and those kind of more sophisticated things. But all the samples went into frozen storage, and we went back to them time and time again as new technologies became apparent. Now, what we found at first was rather startling. Using just this ALT test, we found that over 30% of people with open heart surgery, multiply transfused, developed liver enzyme elevations, which proved by biopsy to be hepatitis. So we had this inordinately high rate. And the reason for that, we found, was that it depended on the source of the blood. At that time, we were buying blood from out of state because we didn't think we could supply our own needs. We found later on that if you received at least 1 unit of commercial or paid donor blood, that 51% of patients got hepatitis, whereas if you received only volunteer donor blood, only 7% got hepatitis. So at that point in 1970, we realized we couldn't continue this practice. We were able to go to an all-volunteer donor system, and you can see the dramatic fall in, well, you can see it anyway, in hepatitis incidence just by changing the source of the donor and by introducing the early tests for hepatitis B. So it went from 30% down to under 10%. And in fact, nothing we've ever done since that time has had so much impact because we've never had rates of hepatitis this high. The next step was that in 1973, better tests for hepatitis B came along. We went back into the stored samples and found that, as shown in the purple, that only about 25% of the cases were due to hepatitis B virus. And there was some other non-B entity that was the primary cause of post-transfusion hepatitis. Then in 1975, Feinstein and Kapickian and Purcell, Feinstein on your right, using immune electron microscopy, discovered the hepatitis A virus. These people were our collaborators. They were right there at NIH. We immediately sent our non-B samples to Steve Feinstein, and it turned out not a single case was due to hepatitis A virus, the only other known virus at the time. So it was then, in a brilliant step of deductive reasoning, that we said if these cases were not A and were not B, we'd call them non-A, non-B hepatitis. Now, we use this very awkward, imprecise nomenclature because we hadn't yet proven that it was a virus, and if it was, we hadn't shown how many viruses it might be. Next step, very important step, was the chimpanzee model. We're not allowed to use the chimp anymore for supposed ethical reasons, but the chimps did not get sick. They got hepatitis by enzymes, but did not get sick or develop chronic liver disease. And they actually love to be in our studies. You can see them lining up here to sign their informed consents. But we learned so much from the chimps that many people thought that they should have gotten the Nobel Prize. In any case, we could show by taking these non-A, non-B samples, inoculating only 1 ml into a chimp, that we could transmit hepatitis to the chimp model from patients who had acute or chronic post-transfusion hepatitis, and also from totally asymptomatic blood donors who had been implicated in hepatitis transmission. So we now had this excellent model, expensive but very precise model. And that led to the next somewhat serendipitous event. Shown here on the right is a patient, Mr. H., who was an inveterate mountain climber and trailblazer. He went around the world marking trails. And one day while up on some precipice, he had a cardiac arrest. And he would have died on that mountain, but his wife was with him, and she knew CPR. She saved his life, and eventually he made his way to NIH. At NIH, he was found to have triple coronary artery disease. He had one of the very first coronary artery bypasses in 1977, saved his life, and then he enrolled in our prospective study. So just concentrate now on this blue curve. That's his ALT levels. You can see at point 0, his level is normal. And then at week 5, the ALT begins to rise. This is the onset of his hepatitis. It rose from 0, or near 0, to over 2,000, where the upper limit of normal for this test is 40. So he had a very severe hepatitis. He was yellow at this time. He was very sick. And he had a classic case of severe acute hepatitis. But then suddenly he got better. His ALT enzymes came down very rapidly. His level of ALT elevation was very minimal, but was intermittently elevated. We followed this patient for 30 years, and I'll show you why in a moment. And he finally died at age 93, but not from hepatitis. He died from his underlying heart disease. So he was a classic case of asymptomatic hepatitis C infection that does not progress. We had 4 liver biopsies to show it didn't progress. But now if you go to the yellow line, first of all, at point A on that curve, we obtained a plasma unit from this patient. We took a small amount, injected that into a chimp, and we could show that it was infectious in the chimp model. And then Bob Purcell, one of our collaborators at NIH, titered this material in other chimps, and we knew then that he had 10 to the 6.5 chimp infectious doses. That number is not important, but what we did have, we had a titered inoculum. We knew exactly how much virus was in that sample. At point B, we did some more pheresis on this patient, collected more plasma, but that sample was not infectious in that chimp, even though it was at the very peak of his enzyme. And that was explained years later by this yellow curve, which is PCR. We were measuring the virus itself. And interestingly, you can see at point 0, the virus is negative. But at week 1, there's a little blip of HCV RNA present in the patient. That's the donor virus that has been transmitted to the patient. Then it gets contained. It looks like it's going to disappear, but then suddenly at week 4, the virus comes back. This is probably a separate strain from the same mutation from the first virus that then takes off, and that's what caused his hepatitis. That's why he got so sick. But then the virus goes away very rapidly. You see that yellow line comes down before the blue line comes down. So the virus is disappearing, his liver inflammation is diminishing, and he goes on to live 30 more years. The important point is now we had this titered infectious inoculum, and we had the chimp model, so that we could perturb the infectious inoculum and see what effect it had on whether it caused disease in the chimp or not. Sorry. So this was an experiment done by Steve Feinstone, where we took that inoculum and he treated it with chloroform. And when he did that on the bottom lines, it no longer caused hepatitis. When he did a sham extraction, shown on the top, it did cause hepatitis in the chimp. So this told us that the virus was susceptible to chloroform, a lipid solvent. And this was very important. It meant that the virus had a lipid envelope. And that, together with other studies that we did where we filtered this infectious inoculum and could size it, we could deduce that the virus must be very small, somewhere between 30 and 60 nanometers in size, have this lipid envelope. That envelope must be surrounding a core. So that told us, before we ever had seen the virus, before we had a specific test for the virus, before we knew much about it molecularly, or anything about it molecularly, it told us that it was probably going to be a small RNA virus, what we call alpha viruses or flaviviruses, or it could have been a hepatitis B-like virus, but we had a lot of evidence that it wasn't related to hepatitis B. And it could have been a totally new viral class, which I suspected it might be, but it turned out to be a flavivirus, as later on I'll show you. But it's amazing what you could deduce with very minimal knowledge, and how important the chimp and the inoculations were, and the ability to change this inoculum. Now, we tried so hard to develop a specific test for this virus, but we used every method known to us in the 70s, early 80s, but could not come up with a specific test. So we concentrated instead on the patients. What did this virus do to patients who had non-A and non-B hepatitis? So we did liver biopsies together with the liver unit at NIH. We initially biopsied 39 patients, and their liver histology, on the most part, was relatively mild or had only minimal hepatitis. But 10% of the patients already had cirrhosis, which is a tremendous scarring of the liver. And another 13% had what we call chronic active hepatitis, which was a very advanced form of hepatitis that would lead to cirrhosis. We then did follow-up biopsies at random times from some of these patients and showed that over time, most of them were stable. Some actually appeared to have better histology over time. But another 25% progressed to cirrhosis under our observation. And we had nothing to do for them. So in the end, we had 8 patients who developed cirrhosis, 8 out of 39, or 20%. Now that number is held up pretty well over time. 20 to 30% of people with hepatitis C move on to have a progressive fibrosis ending in cirrhosis and liver cell death. Importantly, this is now back in the early 70s or mid 70s, we found that 3 of these patients with cirrhosis died. 3 of them had very severe liver disease when they died of their heart disease. And so we knew that this was now not just a liver enzyme elevation, this was a disease that could progress to cirrhosis and could be fatal. But we kept looking. So we now knew about the clinical severity. We knew, but we could not get a test. It was very frustrating. And so frustrating that I then wrote a poem indicating my frustration, which I called "I Can't See the Forest for the HBAGs." HBAG is hepatitis B surface antigen. It went, "I think that I shall never see this virus called non-A, non-B, a virus I cannot deliver, and yet I know it's in the liver. A virus that we often blame, but which exists alone by name. No antigen or DNA, no little test to mark its way. A virus which in our confusion has forced us into mass collusion to make exist just by exclusion. But is it real or an illusion? Oh, great liver in the sky, show us where and tell us why. Send us thoughts that will inspire us. Let us see this elusive virus. If we don't publish soon, they're going to fire us." So that poem, which I, thank you. That poem, which I had the temerity to present at a major meeting, actually had impact because very soon thereafter, Michael Houghton and his team at the Chiron Corporation in California cloned the non-A, non-B agent. And they did this by taking known infectious inocula from the chimp and from the human, pelleting that down to pellet the virus, if there was one, extracting the RNA, cutting that RNA up with reverse transcriptase to make complementary DNA, and then using a new technology, which proved critical, a new phage vector called GT11, which was a bacteriophage that would not only carry the genomic information from any virus, but would express a protein coded for by that virus. So they put this material, they infected E. coli with this bacteriophage, this GT11, grew that in culture, and then took the growth in the agar plates, the clones that developed in the agar plates, put a filter paper over it, lysed the clones, and then screened with what they hoped would be an antibody, but an antibody had never been found. But they took convalescent serum from patients who had recovered or those who had chronic disease. And the story goes they screened 6 million clones before they found a single positive. This is perseverance in research. It took them about 6 years to go through this. In any event, once they had this clone, they could subclone it, express the small protein that was in it, develop an antibody test, and then we had something to work with. So they came, this is Michael Houghton, who at the time he won the Lasker Award. He went on to win the Nobel Prize with me and Charlie Rice. But the Chiron Corporation sent for a panel that I developed, which was a small panel, but it was very tricky, in that every sample was present in duplicate, and every duplicate was in a random position. This panel had confused 19 other laboratories who claimed to have a non-A, non-B test. But Chiron broke the code perfectly. They found 2 patients who had chronic non-A, non-B to be positive in 4 different random positions, 2 implicated donors to be positive, in 3 chronics in 6 different random positions, 2 implicated donors in 4 random positions. They didn't find the acute hepatitis cases because they were looking for antibody, not for virus, but later these patients seroconverted for antibody. And importantly, all 7 negative controls, which were blood donors who had given over and over again and never been implicated, they all were negative. So they had a perfect score. I then looked at 15 of our non-A, non-B cases, and in every case, they were negative for antibody to hepatitis C before transfusion, became positive afterwards. And then we looked for the blood donors to 25 cases, and we found a positive donor in 80%, and by a second-generation test in 88%. So we could presume that if we introduce this test to blood donor screening, we might prevent near 90% of post-transfusion hepatitis, which is exactly what happened. I showed you this beginning curve at the earlier on. In the middle, rates were coming down because we're using much less blood from better sources. But in 1990, we still had 4.1% of patients getting hepatitis. That's when we introduced the first generation test. Whoops, I can't do this. We introduced the first generation test for hepatitis C. The rates came down to 1.1%. In 1992, a still better test came along, and by 1997, we were down to 0 incidence of post-transfusion hepatitis. We've now followed another 1,000 patients and have not had a single case of hepatitis B or hepatitis C post-transfusion. We could estimate that in the 2 decades of between 1970 and 1990, that blood transfusion in the U.S. alone may have caused near 5 million cases of post-transfusion hepatitis. Now, most of this was asymptomatic, but 20% would have gone on to bad disease. Conversely, in 1990, between 1990 and 1910, we could predict that we might have prevented another 2.4 million cases by introducing this test to donor screening. So throughout this time, I was a government employee, and government employees have a bad reputation as being lazy and just working off the government dole. But I just wanted you to know that I always gave 100% at work. It's just that it had this peculiar distribution. What is today? It's Tuesday. This is one of my better days, I think. So, around the world, hepatitis C, we now know, infects about 70 million people who are chronically infected. About 5 million of those are in the U.S. And the reason the rates are so high is that 75 to 85% of people who get hepatitis C cannot clear the virus. There are many reasons why it is, but the main reason is the virus doesn't exist as a single virus, but as a family of viruses called a quasi-species. And as soon as you control one variant, another variant goes on. I think I have one slide to just show you that. We looked at one patient over time leading up to the peak of his ALT. We did 10 clones. Patricia Farsi did this again at NIH. She did 10 clones. And you can see at week 3, the patient had A, B, and C as sort of the dominant clones. These letters have no meaning. They're just to distinguish one variant from another. But by week 8 now D was the dominant clone, but there was also E, F, and G. By week 13 now, you can see A was still there, but no longer dominant. Now you had H, I, J, K, L, M, N, O, P, and by week 16 all the way up to U. So this continuing evolution of different viral variants make it very hard to control hepatitis C by vaccine. The same is true for HIV. HIV does the same kind of thing. So I'm going to skip over this. Can I steal a little more time, Florian? Okay. This was a study we did with investigators in Japan, Dr. Yasuhiro Tanaka and Dr. Mizukami, where we compared genotype 1b in Japan with genotype 1a, and they used what was called molecular clocking, a mathematical way to determine when a particular variant, particular subtype of the virus, diverged from some common ancestor, and then when it spread in the population. And if you look at Japan, genotype 1b shown in the red, you can see that virus appeared in Japan in 1880. It then began to spread in the 1930s and the 1940s, and is now tapered off. Well, what was going on in Japan in the 1930s and 40s was they were at war. They were at war with China, then at war with the Allies. We learned in retrospect that the Japanese soldiers were frequently shooting up with amphetamines, sharing needles, and this is the way the virus was getting spread among the Japanese soldiers. In the US, in contrast, our virus, genotype 1A, diverged around 1910, was then dormant until 1960s, 70s, and 80s when it began to spread. That was when we had our own needle-sharing epidemic, recreational drug use, as well as true addicts. And the reason I show this slide is that there's about a 30 to 40-year difference between Japan and the US. And that's important because Japan has an 8 to 10-fold higher incidence of liver hepatocellular carcinoma, liver cancer. And the Japanese always said that, wait, when you have the virus as long as we had it, you too will have these very high rates of liver cancer. And that has proven to be the case. This is a study by El Sarag in Baylor, where he showed that in the comparing the late 70s to the late 90s, there's been a 3-fold increase in hepatocellular carcinoma in the US, and it's all due to hepatitis C, as shown on the right side. So it was said then that assuming no changes in the standard of care, the total number of patients who are going to have severe outcomes from hepatitis C by 2029 would be 4-fold higher than it was in 2009. And that indeed would have been the case, except we've had a dramatic change in the standard of care. New drugs have come along, so-called direct-acting antivirals, which are highly specific for different enzymatic functions in the hepatitis C virus. They block replication of the virus perfectly. You take 1 pill a day for 8 to 12 weeks, oral treatment, 8 to 12 weeks, no side effects, virtually no side effects, and you are cured, not suppressed, but cured. The virus goes away and doesn't come back unless you're reinfected. So we can now cure 95 to 100% of patients who have hepatitis C with this very simple therapy. Now, during this time, I not only was a government worker, but I was also married. My wife, Diane, is here in the audience. She hates this slide. but at one point, she said to me, "You are the answer to my prayers." And while I was feeling so good about that, she then went on to say, "You are not what I prayed for, but apparently you are the answer." But I've forgiven her for that. So we're now at the end of the beginning. We discovered the non-A, non-B agent. We've recognized that asymptomatic non-A, non-B could progress to cirrhosis and end-stage liver disease and liver cancer. The virus has been cloned. Non-A, non-B has been shown to be identical to hepatitis C. We developed sensitive assays for antibody and for virus, and we virtually eliminated post-transfusion hepatitis. And we developed not me, I had nothing to do with these drugs, but developed these potent direct-acting antivirals. So with that, we can say, could this be the beginning of the end? And the reason it could be the beginning of the end is that why HCV can be eliminated is because there's no non-human reservoir. We don't have to worry about mosquitoes, ticks, anything else transmitting this virus. It's all human to human through percutaneous inoculation. A little bit from mother to infant, but very small. A little bit sexually, but very small. It's mostly needles. We had these very sensitive diagnostic assays, and we have these wonderful curative treatments. So we have everything we need now to eliminate hepatitis C. But how you see this, though, is whether you see the glass half full or half empty. If you see it as half full, you can say, well, with cure rates now approaching 100%, from this time forward, once HCV infection is identified, no one should develop cirrhosis, liver cancer, or die from hepatitis C. But if you see this half empty, and I'm going to go through this, only 40%, 20 to 40% of people who have hepatitis C have been identified. The other 60% are walking around as asymptomatic carriers, and we don't know which of those patients are going to go on and develop cirrhosis. We don't have predictive markers. Access to treatment has been a problem, particularly because of cost. But costs are coming down, and in the third world, or developing world, the companies have dropped the prices dramatically. So if you want to know whether it can be eliminated, Egypt is the poster child. Egypt, who had a high rate of hepatitis C due to using a schistosomiasis vaccine that was contaminated with hepatitis C, given out to millions of people. So Egypt said, we have some responsibility here. What's it going to cost us to get rid of this virus? So they went to the companies, they got around the patent, they developed their own drugs at very low cost. They developed their own assays, their own PCRs. So they did the whole thing, much where it cost now $24,000 to treat a patient in the US. In Japan, they could treat them for about $10. And not in Japan, Egypt, I'm sorry. So Egypt tested 60 million people. That's almost their entire population. And they'd use this test and treat strategy. If you were positive for antibody, they reflexed to virus testing. They found 4% of the population was positive for the virus. They treated them with these miracle drugs. They cured over 2 million people in the years 2014 to 2018. It's just, they've treated everybody now. They retreated those who failed initially. It costs about $50 to $220 US for the tests, for the drugs, for the setting up the infrastructure, everything. It was very doable in Egypt. So the triangulation of HCV elimination is massive global screening with these rapid now fingerstick assays, even fingerstick PCR, immediate delivery of these drugs. So what we mostly need now is the political, the corporate, the moral will to make it happen. And that's where we're stuck now, to get this will behind it country by country. So hepatitis C would be the first chronic disease, infectious disease, in the entire history of medicine to be virtually eradicated by treatment rather than by vaccine. We can make this often failed disease unsustainable. We could do this because it's the right thing to do and because we can do it. However, it won't be me, because I have a new philosophy of life, a philosophic perspective on life, where I've plotted age against give a damn, and I'm over here. I really do give a damn, but I don't have any, I'm too far along the curve to make this happen. But there's a whole host of people, younger people, who are fighting around the world to make this happen. And I think it's going to take decades, but I think it will happen. So thank you very much. Sorry for going over time.
So this is the best presentation ever, compared even to the United States president. He's a government employee, correct? Yes. That's really excellent. We'll have in the gala probably, we're going to have some questions for you as a government employee.
Okay. See if I don't trip.